Welcome to Ask the Expert with Dr. Ann O'Day, Medical Director of Breast Cancer Survivorship and Breast Cancer Clinical Research Program Services at the University of Kansas Medical Center. Dr. O'Day is here to discuss ESR1 mutations in metastatic breast cancer. Should I get tested? Any information presented here does not constitute medical advice. Please contact your healthcare team if you have been diagnosed with cancer, suspect cancer, or are concerned about any aspect of your care. Your own healthcare team is the best source of information about your condition and your treatment.
I'm extremely delighted today. First of all, thank you all for joining another Outcomes for Me as the expert webinar today.
And today's webinar is sponsored by Menarini Stemline.
And I am delighted to welcome Dr. Ann O'Day. Thank you so much for being with us today, Dr. O'Day. Dr. O'Day is certified by the American Board of Internal Medicine with sub-certification in hematology and medical oncology, and she serves as the medical director of the Breast Cancer Survivorship and Breast Cancer Clinical Research Program at the University of Kansas Medical Center. For those of you that don't know me, my name is Maya Saeed. I'm the co-founder and CEO of Outcomes for Me. Outcomes for Me wants to help and empower cancer patients with the tools and resources they need to better navigate your cares. Through our mobile app, and patients can access free resources and information that help them navigate through cancer and their treatments. The format of today's discussion will be a brief presentation followed for a Q&A. We already got a number of questions. Thank you all that have submitted questions, but feel free to submit at any point during the webinar and during the presentation via the Q&A button on Zoom, or if you're on Facebook via the Facebook, questions, any questions, and we'll try to get to as many as possible. If we don't, feel free to submit them on the Outcomes for Me app. We will certainly get back to you after. So without further ado, thank you again for being here, Dr. O'Day. I want to start by allowing you to, kind of help us understand, the question here is ESR1 mutations in metastatic breast cancer. Should I get tested? And I'm going to start also the presentation.
Perfect. Thank you so much, Dr. Saeed. I'm so very grateful for this opportunity to be with you here today, to both Outcomes for Me and Menarini Stemline. As Dr. Saeed mentioned, I am a consultant for Menarini Stemline, and I'm incredibly, as I said, grateful for this opportunity to speak to you today as patients. The goal of today's presentation is really to empower you to start a dialogue with your healthcare practitioner, whether that's an advanced practice provider or your medical oncologist, about the importance of what we call genomic testing. And when we talk about genomic testing of cancer, we're talking about testing the DNA of the cancer. So we all have DNA that we inherited from our mother and our father, and that's our genetic testing. So when we think about being tested for example, the BRCA mutation or the PALB2 mutation, that is genetic testing of our own DNA. But when we test for ESR1 mutation within the cancer, we're testing the cancer's DNA. So this is something that's important for us to understand the distinction. Often I find when I'm talking to my patients and I explain to them that I want to test their tumor for ESR1, they might say responsively, I've already had genetic testing and I don't have any of those genes. So it's an important distinction that we understand that there's genetic testing, testing your DNA, and then there's testing the DNA of the cancer. And so today we're really going to dive into the ESR1 mutation. This is a very important genomic alteration that happens in some hormone-positive breast cancer cells, especially in advanced or metastatic breast cancer. So a very important conversation today, and we'll hope to answer this question for you so that you feel empowered and educated to be able to bring this up to your clinician if you haven't already had your tumor tested for ESR1. And so with that, we will jump in. All right. So important to understand today, we're going to understand that these mutations are very common. So ESR1 mutations, especially in hormone-positive, HER2-negative metastatic breast cancer, almost 50% of people that have hormone-positive, HER2-negative metastatic breast cancer may actually develop an ESR1 mutation after progression on hormone therapy. This is important to understand because these are mutations that sometimes happen over time. So just because you are a patient that has had your cancer tested initially, maybe when you're first diagnosed with advanced breast cancer, it doesn't mean that that mutation won't develop over time under the pressure of treatment. And that's one of the most important concepts we want to make sure that you leave today with, that it's important that you get tested so that you know the ESR1 mutation status of your cancer before you start your next treatment. So today we're going to talk a little bit about what is an ESR1 mutation, why and when an ESR1 mutation might occur, why should you know your status, why is this important to you in your treatment and in your journey as a breast cancer, as an advanced breast cancer survivor, and how and when should you get tested. Next slide. So again, commonly at the initial treatments for hormone-positive, HER2-negative metastatic breast cancer, most patients will receive a hormonal therapy or an endocrine therapy, either with or without a CDK4/6 inhibitor, and there are several of those, for their first-line treatment, or what we call first-line treatment for their advanced breast cancer. And this is really the standard of care within our country. So we're lucky here in the United States that most patients will receive these medications in the front line. Next slide. Oh, and some of the important hormonal therapies that you all might be familiar with, exemestane, anastrozole, letrozole, and fulvestrant. So those are some endocrine therapies that I'm sure that you have heard about or read about. And then those will be prescribed either with or without a CDK4/6 inhibitor. And there are 3 of those that are FDA approved: palbociclib, also known as Ibrance, ribociclib, also known as Kisqali, and abemaciclib, also known as Verzenio. We also see commercials for these on TV. So many patients come to me asking questions about these agents because they may have seen either a commercial on television or on Facebook. And so lots of you have heard of these agents in that situation as well. All right, we know that many people luckily remain on that initial treatment for over a year. The usual time on treatment is about a year or more, although some patients may respond for a less or a shorter period of time, and some patients may respond for a much longer period of time. I have some patients that have been on this first-line therapy with endocrine therapy and a CDK4/6 inhibitor for several years. And so we know that there is a variability in how cancers will respond to that first-line treatment. We know that after the initial success, that a lot of patients will need a change in treatment. Unfortunately, this is something that we see in advanced breast cancer, is that as the treatment goes on, the cancer cells effectively are becoming smarter. They develop mutations, which are acquired ways to become resistant to that cancer therapy. Very similar to if we have an infection, for example, bronchitis, and our primary care doctor puts us on the same antibiotic over and over and over again. Although initially that antibiotic may have worked very well, we see that it starts working less well because that infection is becoming smarter and developing resistance. Cancer cells can behave in very much the same way. Next slide. All right, so now we want to ask you all a question. Have you or anyone you know been tested for an ESR1 mutation? And again, this would be testing your cancer, the DNA of the cancer. And so the options are yes, no, or not sure. And I'd encourage you all to answer the question if you can. We'd like to get some information from you all about how familiar you are with this testing. Great. Thank you so much for being willing to be interactive with us today. We want to make this as relevant to you all as we possibly can. Oh, good. I'm so glad to see that about a quarter of the patients either themselves have had their tumor tested for an ESR1 mutation or know someone, maybe a friend or a family member, that has had their cancer tested for an ESR1 mutation. It looks like most people are not sure. And I think that that is incredibly valid. Sometimes as clinicians, as medical oncologists, we talk to our patients about doing testing and doing testing for targeted therapy, but we don't always use the specific names of the genes and somatic mutations that we are testing for. So I think I'm guilty of this as well as a medical oncologist. I talk about doing testing for targeted therapy, but I don't always specifically give patients a list, for example, of the important mutations that we're testing for. So again, very important to make sure that you all are aware of this mutation and that this is one that you can bring up to your clinician to make sure that any testing that you've had has included the ESR1 mutation. Perfect. All right, next slide.
And we have, I think, another polling question. Give me a second. Here we go.
Perfect. All right. We also want to know, how familiar are you with ESR1 mutations in advanced or metastatic, also known as stage 4 breast cancer? Are you extremely familiar with this terminology? Is this something that you know a lot about? That would be option 1, or option 2, very aware, somewhat familiar, not very aware, or not at all aware. This is a new concept to you. Don't be shy. There's no right or wrong answer. We only want to know what your experience is. Perfect. All right, so it looks like the majority of patients, almost half of you, feel like you're somewhat familiar. So this is a concept that you've heard of. Maybe you've read something about it or talked to your clinician briefly about it. So somewhat familiar, but quite a few patients or those of you on today are saying you're not very aware or not at all aware. So I'm so glad that you're willing to share with us your time today to learn about this important concept. All right, so let's talk a little bit about what is an ESR1 mutation. As I mentioned, over time, metastatic breast cancer cells can change or mutate, and that is they're developing acquired resistance mechanisms under the pressure of treatment. So it's a concept that not a lot of us think about, but when we know that we prescribe treatments, we prescribe therapeutic options for patients, we know that that is going to have an impact on that cancer. And ESR1 is an example of one such mutation. It's a very important mutation because we know a lot about it. We know how it influences cancer and how it influences cancer to potentially metastasize over time. So this is a particularly important mutation that we see that occurs in almost half of all patients that have advanced breast cancer. Next slide. All right, we know ESR1 mutations can cause treatment resistance. And this is because we know that as we rely on that estrogen receptor, we rely on that endocrine therapy to impact that estrogen receptor, that is a rich target for mutation so that the cancer can become resistant to that therapy. So over time, those cancer cells may change. Another word for that is mutate. We know that mutations can cause resistance to certain hormone therapies because, for example, it might cause a change in the binding site where that particular drug might bind. So if the drug can't bind, it can't impact or do what it's supposed to do to the cancer cell. So mutations are something that lead to resistance in hormonal therapies, in really all kinds of cancer therapy, and in other things like infections, as I mentioned, with antibiotics. An ESR1 mutation is one of these kinds of mutations. And for some patients, it may be the reason why the cancer is progressing, why it is growing when maybe that first line therapy that you were receiving was very, very effective. You may have had many months or years when that therapy was working, when you had your CAT scans, for example, or PET scan, and it showed that the cancer was very stable or shrinking. But then over time, we start to see either new spots of cancer or that the existing spots of cancer are starting to increase in size. That may be because of an ESR1 mutation. Next slide. Again, ESR1 mutations can occur at any time during treatment of metastatic breast cancer with hormone therapy. So they can occur at any time either with or without a CDK4/6 inhibitor. So you don't have to have received a medicine like Ibrance or Kisqali or Verzenio in order for the cancer to develop an ESR1 mutation. Again, the likelihood of developing that ESR1 mutation increases over time. ESR1 mutations may make advanced or metastatic breast cancer difficult to treat. This is because it is a mechanism of resistance. So again, it's helping the cancer be smarter, helping it become resistant to the therapies that may have worked early on or in the beginning. There's also some evidence that has been well published that an ESR1 mutation may allow cancer to progress or spread more quickly. So it might encourage the cancer's ability to metastasize to other places of the body. Next slide. Again, ESR1 mutations are common in hormone-positive, HER2-negative metastatic breast cancer, and they may develop during treatment with hormonal therapy. As we mentioned, almost 50% of people that have hormone-positive, HER2-negative metastatic breast cancer might develop an ESR1 mutation after progression on that initial hormone therapy. It's also important to understand that that hormone therapy may have been prescribed for your early stage breast cancer. So perhaps you're a patient that was first diagnosed with stage 1 or 2 or 3 breast cancer, and you were prescribed a hormone modulating medication, either tamoxifen, for example, or anastrozole, letrozole, or exemestane. And your advanced or metastatic breast cancer may have occurred while you were taking that therapy. Again, that's a sign of progression on that initial hormone therapy. Next slide. All right, I'd like to introduce you to a patient. This is Ellen. She's someone who experience might seem familiar to you. Ellen is a 3rd grade teacher. She's very active. She's still doing a lot in her community. She's 63 years of age. She's postmenopausal, and she has been diagnosed with hormone-positive, HER2-negative metastatic breast cancer. She was prescribed initial therapy, or what we call that first-line therapy. She was treated with a hormone therapy and a CDK4/6 inhibitor, and she took that medication for 12 months. Unfortunately, she has had disease progression on her current therapy. So as she has been taking this therapy, her disease has become resistant, and they've seen evidence of progression. So her healthcare team has told her it's time that we might make a treatment change. This is when we talk to our patients about, we want to stay ahead of the cancer, right? We don't want to wait until the cancer is growing rapidly or is out of control, or until you may have experienced a lot of symptoms from your cancer. We would like to stay one step ahead. So we want to be preparing for what that next step is in treatment. So her treatment team has told her it's time for a change. Ellen knows that an ESR1 mutation is common, and that almost 50% of patients with hormone-positive, HER2-negative breast cancer will have developed an ESR1 mutation. So she discusses what might be next in terms of her treatment options with her healthcare team. Again, your cancer's ESR1 mutation status might impact how well your next treatment could work. So depending on what treatment option your healthcare team is recommending to you, whether or not there is an ESR1 mutation there may influence how likely or for how long that treatment may work. So it's important for you to be empowered to know what is your cancer's ESR1 mutation status. Again, these mutations can develop at any time. So you may have had testing for ESR1 mutation when you were first diagnosed with advanced breast cancer, and you may have been told that your cancer does not have an ESR1 mutation. However, we know that these mutations can develop over time. So very important to talk to your doctor about being tested each and every time you have progression of your cancer, as this mutation may have newly developed. All right, so Ellen is getting a blood test to find out if her metastatic breast cancer has an ESR1 mutation. So as a reminder, she was treated with hormone therapy and a CDK4/6 inhibitor for about 12 months. At that time, they saw signs that her cancer was progressing. Her healthcare team told her it was time to try a different treatment or consider a different treatment. And so she had a simple blood test to find out if her metastatic breast cancer had that ESR1 mutation. Again, that ESR1 mutation could be a factor in why her current treatment stopped working. And so important for us to know the status. Next slide. All right, at this time, we'd like to ask you, are you aware currently, if you are a patient, are you aware of your cancer's ESR1 mutation status? The options there are yes, no, or not sure. Again, no right or wrong answers. We just want to be able to engage you and know where you're coming from so that we can make this as relevant to your situation as possible.
Okay, let's see the results.
Okay, so it looks like the majority, 60% of people aren't aware of their cancer's mutation status. This is not surprising. As I said, and some of you may have had this testing done, but your clinician may have not shared with you those results or may have not referred to it specifically as an ESR1 test. It looks like 20% of the people are aware of their mutation status, and that is fantastic. That is great to hear. And then another fifth of you are not sure. All right, so how do you know if your cancer has an ESR1 mutation? Again, this is a blood test, so simple blood test, which is able to pick up on the DNA, the circulating DNA of your cancer within your bloodstream. So blood test can detect if your cancer has developed an ESR1 mutation, and the results may show you why your disease may have progressed. So that may give us some insight into why that is now happening with the cancer, and it may indicate that you need a different treatment. Again, this is a blood test that you can request for the ESR1 mutation each time your cancer progresses while you're taking your hormonal therapy. So very important for you to know your cancer status and to ask for that testing each time you need to change your treatment. As I mentioned, ESR1 mutations are detected through a blood test. The blood test is very accurate and luckily gets the results back to us in about a week. So typically when I talk to a patient about this, I may be looking at CAT scans or hearing about new symptoms a patient might have, and I might have kind of an instinct that that patient's cancer might be starting to change or evolve or might be becoming more active. So I might, in that visit, ask that patient if he or she would be willing to have an extra tube of blood obtained so that we can test for ESR1 mutations, knowing that by the time we get all of the test results back, the CAT scans and so on, that we'll hopefully have the ESR1 mutation testing in about a week. It's very important to find out about the status of an ESR1 mutation when there's more than one tumor in the body, because we know the makeup of every tumor varies just a little bit. This is also particularly important if your cancer or your tumors are in a difficult location. For example, when we have patients that have cancers in the lung, this can be a difficult place in the body to do a needle biopsy or try to obtain a piece of that tumor with a needle. We might risk an infection, we might risk collapsing the lung, and often our radiology doctors that do these tests have a delayed time to get in to get that answer, as opposed to doing a simple blood test can get us that answer in about a week. I always like to explain to patients that when we do this blood test, what it's allowing us to do is to understand, for example, if they have a tumor in their lung and their liver, or even if they have just a few different tumors in their liver, each of those tumors might be a little bit different. And so if we choose to do a biopsy of one of those tumors, we're going to get the information back about the genetic makeup of that tumor that we biopsied. It may not be exactly representative of all the tumors. Some of the other tumors may have different mutations. When we do a blood test, this allows us to account for all of the different types of tumors, which are secreting that circulating DNA into the bloodstream. So I find the ESR1 mutation blood test to be particularly helpful and informative when patients have more than one tumor, or especially when they have tumors in locations that are difficult to biopsy. This can be done at your doctor's office or any lab. Again, it's just a simple blood test. Thank you so much. Next slide. All right, Ellen's blood test results showed the presence of an ESR1 mutation in her cancer. So she is discussing this with her healthcare team about which treatment option is available for her type of cancer. Again, like Ellen, she's a representative patient, but like Ellen, it's important for you to advocate for yourself if your doctor or your healthcare team has not proactively mentioned this as something that you should feel empowered to talk to them about. Before starting your next treatment, ask your healthcare team about getting tested for ESR1 mutations. It's important to know why your current treatment may have stopped working, so you know which treatment options may be available for you. And again, this is something we want to do every time patients that have hormone positive, HER2 negative advanced breast cancer have a change in their cancer or a progression in their cancer. We want to make sure that we get this information because we want to make sure to be treating the most recent or the most current representation of the cancer, understanding that that cancer is always changing over time. So we would encourage you to talk with your healthcare team, to know the status of your cancer, and to get tested, have your cancer tested for an ESR1 mutation. As a reminder, almost half of the people with hormone-positive, HER2-negative metastatic breast cancer will develop an ESR1 mutation after progression on their hormone therapy. So if you have hormone-positive, HER2-negative metastatic breast cancer and your current hormone therapy stops working, you can request that blood test for ESR1 mutations before starting your next treatment. It's important to know if your cancer has an ESR1 mutation, and also to discuss these test results and the next steps with your healthcare team. So ask your healthcare team about getting tested, getting the information about treatment specifically for your type of metastatic breast cancer. Again, this is incredibly important because the cancer is changing over time, and some of the treatments that we might recommend may have a certain amount of side effects, right? And so before we ask you to consider a particular treatment and to perhaps experience some or any of those side effects, we want to make sure that that's going to be the most effective type of treatment for your cancer. All right, now I am so excited to be able to answer some of your questions. And so Maya, Dr. Saeed is going to serve as a moderator for us. I'm committed to answering all of your questions. If your question does not, if we run out of time to be able to answer your question today in the live chat, I would ask you to submit it through the Outcomes for Me app, and I promise that I will get you an answer back.
Will I need additional or specialized monitoring during my treatment due to this specific mutation, or what would that entail?
So that's a great question. So, some patients are very familiar with the germline mutations, like a BRCA mutation or PALB2 mutation, in which we tell them maybe they're at increased risk of other types of cancer, like ovarian cancer. And so we want them to do sonograms of their ovaries and have special blood tests and so on and so forth. This test is a little bit different because we're talking about the DNA within the cancer. So it might make your healthcare team want to monitor your cancer a little bit more closely. For example, if I know that I have a patient that has an ESR1 mutation, and if I'm starting them on that first line therapy with a hormone modulating agent and a CDK4/6 inhibitor, I tend to do their scans to assess the response a little bit more frequently than I would if there was a patient that I knew didn't have that mutation. This is something that might vary from clinician to clinician, but I think it's an important dialogue for each patient to have with their own healthcare team.
Is hormone therapy still a viable treatment option if one has the ESR1 mutation?
So absolutely. The standard of care for hormone positive, HER2 negative metastatic breast cancer is absolutely endocrine therapy. Again, as I mentioned, there's different types of ESR1 mutations, and some of them might be more or less impactful on certain types of resistance mechanisms for a variety of different medications. So this is not a one size fits all. And that's why it's so very important to have a dialogue with your own healthcare team that knows your cancer the best, right? They know how your cancer has behaved. They know what it's looking like, how much cancer is there based on your scans. They know a lot about you as an individual. They know about what's important to you and what your priorities are for your treatment. So important for you to have a dialogue with your healthcare team about that, and really rely on them to help guide you in that regard.
The other question is, well, so let's say, one has the ESR1 mutation. Does that affect how aggressive the cancer might be or how likely it is to respond to treatment?
So it's possible. We know that the acquisition or development of an ESR1 mutation during therapy with hormonal therapy is a common mechanism that can lead to metastasis or resistance to treatment. So it can play a role. Again, not all of these mutations are the same, but it can play a role. And that's one of the reasons why we want to empower patients and healthcare teams to be aware of this so that they can advise their patients about what might be the best options for them as far as treatment.
Are there any clinical trials for people that are specifically have that mutation?
So absolutely. We want all patients to talk to their healthcare team about the availability of clinical trials, understanding that these sometimes are give you access to the latest, greatest treatments before they're available. to the masses. We also know that this is a very altruistic way that patients with advanced breast cancer can help others that may come after them with the same type of cancer. So a clinical trial is something that you should always consider. You would always want to do that under the advice of your healthcare team. I would encourage you to look at clinicaltrials.gov, which is where all clinical trials would be sort of housed, so that you can search even, you can put in that search box ESR1 mutation to look at clinical trials that might be of interest to you and that you might want to discuss with your healthcare team.
That's great, thank you. So we've been talking about ER positive, HER2 negative. We just got a question on the chat here in Zoom, which is the ESR1 mutation a challenge in dealing with an advanced HER2 low ER positive disease?
So this is very important, very important. We know that in the past, we used to educate our patients that they had a hormone positive cancer that was maybe HER2 negative. And now we know we are increasingly looking at HER2 as sort of a continuum. We know that there are cancers that are truly HER2 positive or HER2 overexpressed. There are cancers that are truly HER2 negative or have no expression or zero expression. And there are some cancers that are somewhere in the middle. And so cancers that maybe 5 years ago were classified as hormone positive HER2 negative would now be classified as hormone positive HER2 low. And that is important for patients to understand as the science continues to evolve and therapeutic options continue to evolve. We want them to be empowered, just like with ESR1, to know also about HER2 low. So for patients that have an ESR1 mutated HER2 low cancer, they would still very much be a candidate for the therapeutic options that target the ESR1 mutation. So knowing the ESR1 mutation status is still very important for patients that have HER2 low cancers as well.
So one of the questions also through the live chat here is, can this mutation be turned off?
Wouldn't we all love that, right?
All right.
I think I would have a Nobel Prize, right, if I knew how to do that. Hopefully someone much more brilliant than me with that's running a lab, a basic science lab, will figure out how to do that, right? And that would be something that potentially would be fantastic. I'm not aware of any like genetic manipulation or anything that is able to sort of silence the mutation. It's just looking if the mutation is there. We now have targeted therapy, but something that would sort of reverse the mutation, I'm not aware of that.
How common is it to have more than one mutation, and does it impact the prognosis?
So some tumors will have a multitude of mutations that are sort of co-expressed or present within their cancer. And again, some of these mutations like ESR1 evolve over time. So you may have, when you're first diagnosed with stage 4 cancer, you may have a test which shows that your cancer doesn't have any of those mutations. And then a year later, you may have the presence of an ESR1 mutation and other mutations. And that does happen sometimes. So co-expression is not uncommon, I would say. And again, something that can evolve over time.
If you have your tumor tested and it was negative, would you recommend a second opinion to make sure? Can the pathology testing ever be wrong?
This is perhaps the most important question of the day. And this is something that I'm very passionate about, because working at an academic NCI Comprehensive Cancer Center, we get the opportunity to do a lot of second opinions, review things, and we find a lot of times kind of discordance or things that have discrepancies in pathology. And I always tell all of my patients that the most important doctor that they will have in their healthcare team is the one doctor that they will never, ever meet, and that is their pathologist. We know that part of getting a second opinion includes very much a review of the pathology. So we want to make sure when we do second opinions that we review all of the pathology that has been collected. That's a very, very important strategy. And important for you all, everyone, to talk to their own doctor about that, like to ask the question, should I have my pathology retested? Again, very, very important to talk to your healthcare team about that. We also know that because we can have the tissue itself, so the tumor itself that has been biopsied could have been tested, and we could see, for example, no ESR1 mutation, But then when we test the blood, we may see the ESR1 mutation because, as I mentioned earlier, if you have more than one tumor in the body, they might be slightly different, each of them having slightly different mutations and releasing different DNA into the bloodstream. And so doing that blood test can really help us account for that variability. So we would encourage, again, all patients to talk to their healthcare team, even if they've had their tissue tested for ESR1, should they have their blood tested for ESR1 and other mutations as well. But very important to create that dialogue with their own healthcare team.
And, you're mentioning a blood test, which is something that's actually, have been more recent in breast cancer treatment. Like typically, I think, the genomic profiling historically in breast has not been a blood test, if I'm correct.
That's exactly right. When the next generation sequencing, also known as genomic testing, when NGS or genomic testing, all of that is kind of sort of interchangeable. When that first came about, we thought we had to do it using the tissue. So we would do it based on the biopsy that led to the diagnosis of advanced breast cancer. And if that wasn't available, we might even go back to the primary tumor and we would look for these mutations, whether or not they were present. But what we now know is that the blood tests are very accurate for a lot of patients and can give results in a sort of a lot of times more quickly and without the risk of additional biopsies, and can allow for that tumor heterogeneity. So if you have different tumors in different parts of the body, the blood test is going to account for that, as opposed to having to do maybe 6 or 7 different biopsies of different parts of the body. So absolutely, the shift from tissue to blood is something that is relatively new and is something that we're all starting to incorporate more into our practices.
That's great. Dr. O'Day, I know we took a few minutes over. Thank you so much for your time.
Thank you. It was a privilege.
Thank you so much. And thank you all of you for being with us today. If you do have any questions, follow up, please make sure you submit them via the app. It's free. You can download it on the stores. And then finally, if you have any suggestions for any topics for our next webinars, please don't hesitate to send us your suggestion. With that, again, thank you so much, Dr. O'Day, for being with us today, for sharing this invaluable information. And thank you all for being with us. Thank you.
Thank you.
Thank you.